Hello and welcome to Lecture 22. This is Ward Stevens, and in this lecture we're going to talk about two things. The first is new payment models, and the second is this area known as value-based purchasing. Now, from previous lectures, we know that there's been significant progress in decreasing the number of uninsured individuals in the United States, currently about 8% of the population. Back in 2010, the percent of individuals that were uninsured was approximately 16%. But how have we done on cost? Not quite as well. Is care more affordable? And again, as I think I pointed out before, it kind of depends upon who you ask. The overall cost per person has increased about 60% since 2010, while the general inflation rate has gone up about 37%. However, need to note that while the cost per capita has gone up, so overall things are not not really less costly. If you did not have insurance before, the cost of healthcare is certainly less expensive for you. Now, you will also recall from a previous lecture that the Affordable Care Act was kind of described as two phases by Donald Berwick, who was the administrator for the Center for Medicare and Medicaid Services when the law was implemented. And he had been and still is with the Institute of Medicine, or the Institute for Healthcare Improvement, and he had a lot of input into how the bill and the law was put in place. But he described the ACA as having two phases. One was the coverage agenda, basically providing people insurance coverage who did not have it before. That pretty much lasted from 2010 to 2014. But as part of his phase one description, he noted that it was not going to solve the problem because it's not sustainable. And what did he mean by not sustainable? Well, one is it wasn't sustainable in regards to cost, and also not really sustainable with regards to the quality of care. So he described the second phase as the systems improvement agenda, with the goal of making the security achieved in phase one sustainable, and that the way to achieve this was to pursue the triple aim of better care, better health, and better cost. And he was quoted as saying at a meeting back in 2011 that if we don't improve it, we can't afford it. It is simple as that. Now, there are a lot of medical terms that you have probably heard: CHF for congestive heart failure, COPD for chronic obstructive pulmonary disease, and others. And the number of acronyms that we have out there in healthcare are very, very, very numerous. And as a to be a medical professional, some of these you are probably well aware of. But there's a whole nother group of acronyms out there, such as ACOs and ACAs and MACRA and MIPS and QPP and others, that have nothing to do with diseases. Well, there might be an acronym out there, might be a disease that has the acronym of ACO or ACA, but I'm not aware of it. But these aren't diseases, but these are things that are going to impact you as a physician. It'll impact physician assistants, and they'll impact patients as well. So by the end of this presentation, there are a number of things that I hope you will be able to recall and recognize, and also to understand. And these here are just in relationship to the new payment models. There's some more learning objectives later in this presentation regarding value-based purchasing. So we'll get to those after a bit. So we've talked about cost before. We've recognized that there are sources of wasteful spending that are out there, whether that's clinically ineffective services, high prices, inefficiencies, and fraud, and other issues as well. And back in 2013, and again, this is a number that still gets thrown out there a lot. Maybe this number is higher, maybe it's lower. I'm not sure how inflation adjusted this would impact this. I'm not sure. But the Institute of Medicine estimated that we were wasting about $765 billion a year. And that's a lot of money. money that could be better put to better uses, perhaps providing care to the uninsured, perhaps letting taxpayers keep it, or whatever. But a lot of waste out there. And it's wasteful. But what are some other reasons we want to address healthcare cost? Uh, One is to remember that wasteful spending does not improve health outcomes. It's a waste. We know that many families cannot afford health care, even if they have insurance. The cost sharing may be too high for them, or the premium or the percentage of the premium that they have to pay might be too high. So, might it, if we can eliminate cost, might we be able to make it more affordable for individuals? And then we could also use this money elsewhere. Maybe our education system. Maybe we need some new bridges. Maybe we need whatever we need to do in the country. But we can. I think it's pretty easy to argue that the healthcare system is consuming a very large part of our economy, particularly when compared to other nations, and we could do better by doing a little bit less. And then it also contributes to inflation and to our national debt. Of those things we have talked about before. And then there also have been issues with fee-for-service reimbursement. Again, it's a little repetitive compared to the previous lectures, but directly related to what we are talking about now. And just remember that fee-for-service is basically price times the quantity. And that some of the issues that we identified before was that fee-for-service medicine encourages overutilization. If I do more, I get paid more. Not that, everybody would do this, but if I could, maybe I should just go ahead and do that study. It's good for me financially. It minimizes the financial risk to providers. All of it is the financial risk is based or placed on the patient or whoever else is paying the bills. And also discourages collaboration between providers because every provider gets paid for what they do. And that overutilization, because of the incentives to do more, can increase the risk to patients. The more times you stick a person with a needle, the more times you have an opportunity to damage them. And this as well is, just ask yourself these questions. What incentive does fee-for-service payment have to control expenses? Really none. Who is at financial risk? We know who that is. That's the person who's paying it. No incentive to collaborate. And again, it puts the patients at risk. So it's kind of a repeat from the previous slide, but nice pretty pictures on it. Now, we also know, besides the cost problems, that there are quality issues in the United States as well. Some more current estimates are that there are about 210,000 unnecessary deaths that result from healthcare in our country. I mean, that's equivalent to 3 Boeing 737 Maxes crashing every single day here in the United States. And you would just have to ask yourself, if you knew that 3 airplanes were going to drop out of the sky in the United States every day, how likely would you be willing to get on an airplane? I guess the only thing fortunate about it, if 3 dropped out of the sky every day, eventually there might not be any airplanes and everybody would be safe. But we wouldn't want that either, because we like to travel. But it's a big problem. It's been estimated that about 25% of hospital patients experience some type of harm. One, it could be a preventable death, but it could also be, wrong medications or delayed care or whatever. And that doesn't even, these numbers don't take into consideration harm that might occur to patients in other settings, such as outpatient surgery centers or physician offices or where have you. And it's the quality issue is expensive. An estimate was it costs about $1 trillion a year. So how do we go about addressing these cost and quality issues? Well, we go after the triple aim of providing a better experience of care, which is safe care, providing a lower per capita cost, and then population health, or better outcomes. So how do we do this? How do we wed these goals with the finances? So a concept that is out there is pay for performance, also referred to as P4P. And the purpose of these is to encourage the healthcare system to pursue the triple aim, and to do that by rewarding quality medical care. Now, this is about a 15-minute video you may want to take a look at. I think it does a good job in explaining what pay for performance is all about. So if you like, take a look. So pay for performance, basically, essentially, as I said before, rewards quality medical care, and in addition to that, providing evidence-based medicine. We don't want to provide care that there's no evidence that it works. I think that's pretty logical. A concept that is also relates back to value-based insurance design, right? So you want to do stuff that works. So as a result of the Patient Protection and Affordable Care Act, the ACA, is that it authorized the Center for Medicare and Medicaid Innovation, which is I'll call it a subsidiary of CMS, the Center for Medicare and Medicaid Services. So this is a center located in within CMS. So what they were charged with was testing new payment models that lower cost and improve quality. And there are a couple of them I would like you to know. And one is accountable care organizations, or ACOs, and then the others are bundled payments. And ACOs and bundled payments are often referred to as advanced payment models, or APMs. Okay, so we got ACOs and APMs, and I will bring back real quickly, PCMH is also recognized as an APM. However, it was not created as a result of the Affordable Care Act. So let's talk about the ACOs and bundle payments. ACOs are essentially just a group of providers responsible for patient outcomes and cost. And this provider group can be pretty much any group of providers that want to get together. It can include hospitals, physicians, nursing homes, other home health agencies, other outpatient services. And the ACOs are managed by what is known as the Medicare Shared Savings Program. And this group of providers, they come together, they contract with the Medicare program, and they must demonstrate improvements in quality. And these results are reported to the public, and the payment that they received is based on cost and quality performance. So essentially, an ACO is an organization that becomes responsible for a group of patients, and their payments to them are based on cost and quality, and however they do gets reported to the public. So here's another relatively short video, if I recall correctly, that you might want to take a look at, and just kind of give a brief overview of what an ACO is all about. Now, ACOs, there's two types, and this is important to remember. One is that they are either one-sided or they're two-sided. And so on the cost side of things, the Medicare will contract with the ACO, and if the ACO and will basically be paid a fixed amount per person that is in the ACO. And in the Medicare program, to become part of an ACO, all the patient has to do is show up at the hospital that is part of the ACO. So It doesn't require any action on behalf of the patient. It doesn't impact what the patient has to pay, but it does impact what the ACO will receive. So the ACO receives a flat payment per person, and they are expected again to focus on quality, but they also have to focus on cost. And if they actually save money, they get to keep about 50% of the savings if they are part of a one-sided ACO. So really no too much of a risk joining a one-sided or being a one-sided ACO. However, if the ACO feels pretty good about their ability to save money, they can become a or participate as a two-sided ACO, which means that they share in savings and losses. So if they lose money or they don't achieve the savings, then it's going to cost them. And I don't have a more recent number on this. Probably could find one, but a relatively small percentage of ACOs choose to take on the possibility of financial losses by participating in the ACO. So there's an incentive to do well financially, to lower the cost. But it's just not lowering your cost isn't going to make you a successful ACO. The other thing that an ACO has to do is to report on quality benchmarks, typically in four different areas: the patient's experience, patient safety, preventive health, and some measures regarding at-risk populations. So I think just the important thing here to remember about an ACO is that they can save money, but if they are not providing quality care, then they're not going to realize the savings that they had hoped. And so you can see in these different areas there's numerous measures in each. Not really helpful to try to remember what those that 8 and the 10 and the 8 and the 8 and the 5. Just remember that ACOs have to meet quality benchmarks. So how are ACOs doing? So back in about 2017, there were about 428 ACOs at that time, serving about 10 million beneficiaries. And it was reported that they reduced spending by about $1 billion. So that's pretty significant amount of money. And they also showed an overall improvement in quality. So the incentive is there to control cost, to provide quality, and ACOs up through at least that point in time showed some levels of success. Now, the second advanced payment model that has been implemented by CMMI, or the Center for Medicare and Medicaid Innovation, or bundled payments. And a bundled payment is essentially an episode of care payment. We talked about the different payment models in a previous lecture, the fee for service, the per diem, global payments, capitation, and then the episodic or episode of care payment. And an example of that might be a patient who is admitted to the hospital following a hip replacement, and we cover that hospital stay plus any types of services provided 90 days post discharge after they leave the hospital. And what is I guess an example of an episodic care payment you may recall from the Medicare presentation was the MSDRG, which pays by type of the diagnosis of the patient. But the interesting thing with bundled payments is that there's one payment that has to be shared by all providers. So if that patient comes in for a hip implant, the surgeon, the anesthesiologist, the hospital, perhaps the rehab or home health that occurs after that, all have to be paid out of that lump sum payment. And like the ACO, these payments are are tied to various quality measures. And those quality measures are reported so that individuals can can see that if you're interested in looking at it. So, I mean, pretty simple, but an advantage of it is it's really encourages providers to collaborate for that episode of care. And you can say the same thing about ACOs. If the system's not collaborating or the different parts of it, they will not be successful. So we also have a relatively short video on bundled payments that you might want to take a look at. And also another one from Remedy Partners back in 2017, which I also think is good. So I'd encourage you to watch that as well. So we have these advanced payment models. What is required for success? So characteristics of successful APMs include having processes to manage the sickest patients. So if you are responsible ACO and you have a lot of say asthma patients, it's very important that you manage their care to keep them from preventing to have to go to the emergency room or be admitted to the hospital. Just having electronic medical records and the ability also to communicate with patients. It also requires strong hospital and physician relations, because if you don't have those, there's no way that things are going to work. And I believe that this move toward ACOs has provided some impetus for more hospital system to want to directly employ physicians. And it may be a reason why physicians are employed by systems. And then at the practice level, say at the primary care level, just the use of care coordinators. Think patient-centered medical home, federally qualified health clinics, and the like. And it also requires a team approach to care and expanded office hours. So part of this to be successful as an APM is related to the inpatient side, but also the outpatient side as well. So we have a number of abbreviations that you might want to remember there. I do encourage you to watch the several videos that were included in this part of the presentation. So we're going to move on to the world of value-based purchasing, and excuse me. And this section of this lecture has some learning objectives associated with that as well. So the goals of value-based purchasing, all right, and it provides financial incentives to hospitals. So we have value-based insurance design, that's insurance company stuff. We have the advanced payment models, which we've talked about, that kind of address not only hospitals, but working across organizations and types of providers. But the value-based purchasing program is focused on hospitals only. So try to remember that. But the goals of the value-based purchasing are to basically provide financial incentives for hospitals to basically do the right thing, follow the processes, achieve desirable patient outcomes, and also to provide cost-effective care. Now, under value-based purchasing, there are 3 programs that I'd like you to remember. One is the Hospital Value-Based Purchasing Program, also known as the HVAP or something like that. We also have Hospital Acquired Conditions Program and the Hospital Readmissions Reduction Program, or the HRRP. So we have HVAC, HAP, and the HERP, or something like that. However you want to pronounce it works well for me. So let's talk about the first one, the Hospital Value-Based Purchasing Program. What this program looks at are things like mortality and complications, healthcare associated infections, patient safety, patient experience, and efficiency and cost reduction. And so these measures are looked at, and payments to the hospital are based on a total performance score. And the thing about this program is not only does it include bonuses if you do well, there'll be penalties if you do not compare favorably to other hospitals across the United States. And these measures pretty much are spread across 4 different domains: clinical outcomes, person and community engagement, safety, efficiency, and cost reduction. So we'll talk a little about each of those 4 areas. Within the clinical care domain, some sample measures that are used are things such as deaths within 30 days after entering the hospital for acute myocardial infarction, heart failure, and pneumonia. And then complications associated with total NIP and HE surgeries. So these things are all measurable. And if you were to go to, I think healthcare.gov, medicare.gov, or where you can do hospital comparisons, can't remember the exact site, many of these numbers will be reported so that individuals can go and look and see how these hospitals are doing. Now, the second area is person and community engagement domain. And a lot of this is coming from surveys that are completed by patients. Under such, we'll ask questions such as, did the doctors and the nurses talk to me and tell me what was going on? How long did it take for the staff to show up when I pulled the bell? How clean and quiet is the hospital? Was my transition of care from the hospital to the skilled nursing facility smooth? And also provide overall hospital rating. So this is just highly dependent on the patient's perceptions of the care that they received. So these measures are collected through a thing called HCAHPS or HCAHPS, the Hospital Consumer Assessment of Healthcare Providers and Systems. And it measures those items that I talked about before. And the goal of the system is to just kind of have a standardized way to collect and report information from the patient's perspective, and also to create incentives for improving, and also to make the quality of care transparent. And in my experience, having these numbers out there can really encourage healthcare organizations to improve. Kind of a local example is a hospital where I worked did very well on these measures. And the medical staff, I think, was kind of beating themselves up for, I don't know, they just seemed down. So we shared with them the results of that hospital survey in comparison to the competitive or competing hospital about 10 miles away. And this hospital where I was, that it wasn't because I was there. I hadn't been there very long. Certainly didn't impact the results because I never talked to any patients, or not enough to make a difference. And not that it would make a difference, but the other hospital did not fare. And it wasn't too long after that the CEO from the other hospital, we were friends, competing friends, but friends nonetheless, shared that was the best thing that ever happened to him, because having those numbers out there amongst the medical staff really encouraged the other medical staff and the hospital team there to improve their results. So, being in a competitive market, and that I think most people who work in healthcare at some level are competitive, you don't want to be out competed. So, the information can be used for good. The third domain is just the safety domain, which primarily looks at the number of infections related to things such as Clostridium difficile and methicillin-resistant Staphylococcus aureus, and infections associated with catheters and urinary tract and central line placements. So that is looked at as well. And you can see all this information online for any given hospital. And then the fourth area just kind of looks at the efficiency and just cost reduction. And they kind of look at measures per or cost per Medicare beneficiary. And they also look at the cost, 3 days prior to an admission and 30 days after discharge. Now we have that system now, and it collects all this information. And as I said, it impacts payments. And so in 2013, these payments impacted about 1% of all DRG payments. So remember the DRGs, how Medicare pays for inpatient stays, and it kind of grew over the next few years, and currently about 2%. And so what happens is the hospitals that do well could get up to a 2% bonus of their DRG payments, total DRG payments, and that is paid for out of the pockets of the low performing hospitals. And there have been some criticisms of that, because oftentimes it seems that low performing hospitals are located in lower economically viable areas, maybe treat sicker patient populations, and now you're taking, which are, that all has its own challenges, and then you're taking money out of those hospitals who need the money the most in order to try to improve care. And that's been a criticism of these systems. So that is the hospital value-based purchasing program is one program that is out there, but there's another one as well. And you'll start to see that these programs in a little bit kind of overlap themselves. So hospital acquired conditions, what are they? Well, exactly as the name implies, those are things that happen to you because you show up in the hospital and probably shouldn't be. So this program provides some financial incentives to try to avoid what one would say are preventable complications. And one could argue whether it was really preventable or not, but the program says that they are. And 85% of the penalties are tied to hospital-acquired infections, which can account to up to about 100,000 deaths per year in U.S. hospitals, and then the remaining 15% tied to other complications. And these things, just like the other programs, is the results are available at hospital.gov. So there are, as I mentioned before, 85% of the penalties are tied to the list that is there. Things, several of those which we saw in the previous program, but there are basically 10 other items out there for things like for the other 15% of the penalties that, for examples are pressure ulcers, falls, patient falls in the hospital and they fracture their hip, and then sepsis as well. And then of the other 6 are all of those 10. You saw the first 4 are related to surgical care, and you can see how see them listed there. So how does the penalty work on this program? Well, the lowest quarter hospitals are penalized, and it can be up to 1% of a hospital's Medicare collections. So it's just not related to the payments for the hospital or for the patients who may have had less than favorable outcomes. It applies to every single patient, every single dollar from the Medicare program that could have been collected. And this is in addition to the penalties of the hospital value-based purchasing program. So I think the number was 2% before, and this is 1%. So you could lose, just between these two programs, about 3% of your Medicare margins. And then, though, that's not the end of it. We also have the hospital readmission reduction program, which addresses readmissions to hospitals within 30 days of discharge. And when I worked in the hospital, and I never ever thought about it, but one day was looking at, I'd read an article that said that, about 25% of patients being admitted to hospitals had been discharged from the hospital within the last 30 days. And I looked at our hospital's number and found that about 25% of our patients had been discharged from the hospital within the last 30 days. And so the goal of this program is to try to change that trend. Because if you think of the finances of it, is if a patient leaves the hospital gets paid for the discharge under an MSDRG. If they go across the street, which was in our situation the way it was, they go to the skilled nursing facility, and the skilled nursing facility gets paid. And then if something happens in the skilled nursing facility, then the patient comes back to the hospital again, and they get paid again for another MSDRG, oftentimes for the exact same thing. So there was no financial incentive to make sure that the patient left the hospital and that they were ready, that the nursing home was going to do everything they needed to do. No emphasis whatsoever or financial incentive to try to coordinate care between different organizations. So in 2011, and this is use these numbers because that was when the program started, but roughly about $24 billion. So currently, the hospital readmission reduction program covers 6 admissions. You can see them listed there: acute myocardial infarction, heart failure, and so on. And this list hasn't changed since the program was implemented, or it hasn't changed since around 2018. So how did this program going to impact payments? Well, it can impact 3% of a hospital's Medicare payments. So it's pretty significant. And hospitals certainly don't want to do that or incur those reductions in reimbursement. So how do you avoid HAC and HERP penalties? One is there needs to be a focus on coordination of care outside the hospital, because if they come back, you're gonna be penalized. The second is a focus on evidence-based practices and doing it consistently. And then a really big one, which is so very simple, is just proper hand washing. And I can't emphasize enough how important that is, but it's almost kind of scary that even though that we know this, that healthcare providers are often not very good at washing their hands. And while this was a few years ago, I had a friend who was an infectious disease doctor who went to a national conference of infectious disease people. And while during that conference, they did a study of hand washing practices following use of restrooms, and found that only about 50% of the attendees of that meeting actually washed their hands. So hopefully they did better when they were in the hospitals. But it is a problem. So don't be part of that problem. I could even ask a question on that. So the results are available publicly. So you can always go see what your local hospital is doing. And I talked about the penalties before for each of these programs, but I just wanted to show you a sample from a very poorly performing hospital. Now, the Medicare revenue number is actually from a real live hospital. It doesn't matter. And this hospital did not receive these penalties. But if you look at the maximum 2% penalty for the HVAC program, roughly $2.2 million. The HAC penalty of 1% of about $1.1 million. And the hospital readmission reduction program of about 3%, $3.3 million, you're talking about $6.6 million in lost revenue. And the thing about Medicare and the way that program is designed, it is essentially its goal is to cover the hospital's cost for providing care. And some things you do make money on, other things you don't. But there's not a whole lot of margin in a hospital's Medicare business. And so if you lose $6.6 million, even if you have 110 roughly million dollars coming in, that's a very significant financial penalty. So these are programs that are out there. They're not going away, and they will impact the way, or should impact the way, that you provide care to your patients. So there's some abbreviations you'll probably want to remember, and then a whole slew of references here on these topics. And thank you for listening, and let me know if you